Good morning, I'm Dr. Liu from Opom Sabah. I'm going to show you a few videos on oral biopsy technique. These are the techniques that are usually practiced in dental services. Smear, which is one of the exfoliative cytology, is commonly done in oral medicine clinic to rule out fungal infection. It's a cytology because we are examining the cells rather than tissue. Okay, then for mucosal biopsy, we have incisional biopsy and excisional biopsy. The instruments that are commonly used include scalpel, a punch, or electrocautery or laser. Sometimes we do smear to rule out candidal infection. So these are the materials that needs to be prepared before a smear can be done. First of all, we need to have microscope slides as shown in the picture with patient's name and date label. Okay, and also we need to have a tongue depressor. Okay, and then we need to have a fixative solution, which is alcohol 70%. Alright. This patient is having burning sensation over his dorsum of tongue, so a tongue depressor is used and to gently scrape his dorsum of tongue. Then the exfoliated cells will be spread onto the slides. The cells will then be spread evenly on the slides using another piece of microscopic slide. The slides will be left for a short while to dry and then will be placed into the alcohol container, and this will be sent to the lab immediately for staining. And this is what we will see under the microscope when there is fungal infection. The purplish strands are fungal hyphae, while the pinkish material at the background are the epithelial cells and cellular debris. These are the basic instruments and materials that we need in a biopsy. First of all, get ready the specimen bottle before the biopsy starts, and make sure patient's detail including name, IC number, and also site of biopsy, time of specimen taken, and also date has been filled up prior to biopsy. Here we have our basic examination set including probe, tweezer, as well as dental mirror. And we need to administer LA prior to biopsy. So get ready the syringe, LA solution, as well as needle of suitable size. Then your scalpel and blade. Usually we use blade number 15, and sometimes in certain biopsy, blade number 12 can be used. So we have non-tooth tissue forceps and a tooth tissue forceps. Please be careful when you are holding the specimen with the tissue forceps, as extra pressure on the specimen will cause crush artifact. And you may use a cheek retractor or tongue depressor if necessary. And also need to standby suture material. It can be a 3/0 or 4/0 silk suture. And it can be used for, apart from wound closure, you can use it to hold the specimen or the lesion when you are excising it from the oral cavity. And also a nylon suture will be useful if you plan to retract the tongue, for example. Okay, and also artery forceps and needle holder. I believe you can differentiate what's the difference between artery forceps and needle holder, although these two look the same. And scissors for tissue and suture. And hemostatic agents such as Giselle as well as gauze. Okay, here's a table by Oliver et al. In 2004. The authors proposed guidelines for an appropriate biopsy. So, for example, in a clinical diagnosis of chronic ulcer or to rule out SCC, incisional biopsy can be done at the margin of ulcer. Okay, and also it is better to avoid it to be done at the central necrose area or at the friable part. What we are going to say is it could be non-specific findings like chronic inflammation, which could have masked the true pathology. Okay, so this is very important. All right, and at the margin of ulcer means you could include a small area of surrounding normal mucosa. Okay, so the pathologist can compare the normal area with the lesional area. Then, for example, like mucosal lichen planus, now you see white striation and also probably some red area. Okay, these are the areas for biopsy. But if you encounter like extensive ulceration or extensive erosions, please do not do biopsy over those areas, as you are going to get non-specific findings like chronic inflammation or non-specific ulcer. Alright, so I hope this table will help for you to select area of biopsy. This is a case from Avon and Clip in 2012 of homogeneous leukoplakia at the right lateral border of tongue. Okay, LA was given as shown in figure B, and then an elliptical incision was made with a length to width ratio of 3:1. Usually, an elliptical incision is preferred for a better primary intention closure. The figure shows 4-point technique of LA administration. LA should not be given too close to the lesion, as cellular edema may be confused with the true lesion. Additional LA infiltration can be given for better anesthetic effect. Here we have an ulcerated growth on the mucosa, and I have selected the area for biopsy. So LA was given at the 4 points surrounding the biopsy site. And this is followed by incisional biopsy at that area. So in this case, I'm using a non-tooth tissue forceps and with a scalpel. Elliptical incision was made, although it doesn't look so perfect as in 3:1 ratio of length to width. Okay, the growth is included, the reddish area is also included, and some of the normal mucosa. Okay, now the specimen is ready to be placed into the specimen bottle, which contains formalin solution having volume of 15 to 20 times of the specimen size. Okay, and then you must avoid to place the specimen on dry gauze. If you happen to not to be able to place the specimen immediately into the formalin, for example, a big surgical specimen or a big solid mass that you might need to place some orientation suture, or you might need to do some labeling on a cardboard or anything, then you can put the specimen on a damp gauze or gauze soaked with saline. Okay. If you are having a small specimen, the specimen can be placed on a rigid piece of paper, for example, the packaging of the suture material, before placing it into the formalin solution in the specimen bottle. This could prevent the tissue from rolling around itself and collapse, which will make it more difficult for the pathologist to orient and interpret the specimen later. Here's another technique of doing incisional biopsy. A suture is placed for it to be easily held during the procedure rather than using a tissue forceps. So the needle is just placed across the lesion and then pulled. Then the suture is tangled around the beak of artery forceps and then pulled, and you can just continue with incision in this way. Similar technique was used in this patient who has a non-healing ulcer on dorsum of tongue. A mouth prop can be considered if patients having limited mouth opening to avoid injury to the surrounding oral mucosa. In this case, a knot is made and this will be held with an artery. Then incision continues. An elliptical incision was made. And an area of normal mucosa is also included. Okay, so there is some bleeding, and assistance is not to just retract the tissue, and also sometimes have to stop the bleeding and clear the view for the surgeon. Suctions can be placed, but be careful, don't place it near to the base of lesion, but just gently swipe around the lesion or the biopsy site. Then specimen placed into the formalin, and please do not reuse the instrument if it has been in contact with the formalin. As mentioned just now, do not place the suction tip directly at the base of biopsy, but just place it at the surrounding area. Alternatively, you can also use a gauze to stop bleeding. This is a disposable punch. Usually it is used in skin biopsy, and in some cases of oral biopsy it can be used as well. So we can see there's a circular blade attached to a plastic handle. So a punch can range from 1 mm to 8 mm in diameter. And in this case, the punch shown is 6 mm in diameter. The reddish spot is an ulcerated lesion, and I'm going to do punch biopsy using this punch number 6. Please note the cutting area is a circular blade. Before cutting, we give LA first. Then the punch is placed perpendicularly to the lesion. And then for cutting, rotate the punch clockwise, and with some gentle pressure, push the punch inwards. So keep rotating and it will cut. I cut it at about 5 mm depth. Then slowly I rotate anti-clockwise to remove the punch. Now we can see there is cutting mark. And I use a tissue forceps to gently hold the specimen. Then I use a scalpel blade to carefully incise the base of the lesion. Alternatively, you can also use a tissue scissor to remove it from the base. Okay, so now we have the lesion, and the specimen should be placed into the formalin as soon as possible. In this case, punch biopsy can be done at sites having sufficient thickness. Areas such as hard palate or gingiva would not be suitable, as closure would be slightly difficult. For vesicular bullous lesions like pemphigus vulgaris or mucous membrane pemphigoid, which is more commonly encountered, DIF or direct immunofluorescence can be considered as one of the tests apart from routine H&E. So in this case, perilesional skin will be taken as specimen instead of the blister. And after the biopsy is done, the specimen will be divided into two. One will be immersed in formalin, and another half will be sent for DIF. We will avoid using punch biopsy, as this would possibly detach the epithelium and prevent proper assessment of the interface between epithelium and connective tissue. In DIF, when there is reactivity between the antigen and the antibody stain, for example IgG or C3 or fibrinogen, under the fluorescent microscope, we can see net-like deposition of the antibody within the epidermis or epithelium. Please do not use formalin for fixation. You can choose to use Michel solution as a transport medium and just place the specimen into the solution. Alternatively, you can use phosphate buffer solution as a transport medium if you don't have Michel solution. You can either place the specimen on the gauze which has already soaked in the solution and then place it in a specimen bottle, or just directly place the specimen into the solution in the specimen bottle. Get ready a polystyrene box like this with ice pack inside the box and place the specimen bottle inside the box. Close the box with the lid and send it to the lab as soon as possible or immediately. And if you have liquid nitrogen as a cooling material, you can use it as well. Excisional biopsy is done to remove the lesion in total. So usually we will include margin of normal mucosa. And sometimes orientation of the specimen is important to tell the pathologist where is the direction of the specimen. So suture can be placed to indicate the orientation, and labeling should be done in the pipette form. In this video, I'm showing how a suture is made at the margin. Okay, you can choose to use a simple interrupted suture, or you can make a loop to indicate different margin. Sometimes you can include like 2 long sutures or 2 short sutures, or 1 long 1 short sutures to indicate different margins if there is multiple margins in the specimen, especially in a big surgical specimen. Occasionally, when we use electrocautery or laser for excisional biopsy, we expect there will be some thermal damage. Therefore, 0.5 mm margin should be maintained between the cut and the representative area to be sampled. If you happen to encounter the lesions as shown in the picture, for example, you suspect mucocele or a fibroepithelial polyp, excisional biopsy can be done. These are the references I use for this presentation. With that, I thank you.